So it's my pleasure now to introduce Wesley Moore, who's going to deliver the John Homan lecture for us today. Mentor, colleague, and friend. It's my privilege today to introduce someone who has served all those roles for me and more, as he gave me a chance to be a vascular fellow at UCLA years ago, and he will be our John Homans lecturer today. You all know Dr. Wesley Moore. He's a pioneer in vascular surgery. He's recognized as an expert in the surgical management of many diseases, but specifically today we've asked him to talk about carotid artery disease for his strategies and his thoughts for stroke prevention. He's been a participant and a leader in major clinical trials, including the VA Asymptomatic Carotid Stenosis Trial, the North American Symptomatic Carotid Stenosis Trial, or NASIT, the Asymptomatic Carotid Stenosis Study, or ACAS, and most recently, the Carotid Revascularization Endarterectomy versus Stenting Trial, the Crest trial. He's always at the forefront trying to answer the questions on cerebral vascular disease and has edited the definitive textbook for cerebral vascular disease. Dr. Moore graduated from the University of California, San Francisco Medical School and completed his general surgery training there. He then spent 2 years in the United States Army as chief of surgery of the 98th General Hospital in Germany before he came back to San Francisco to train with those amazing leaders in vascular surgery. He joined the faculty at UCSF and served as chief of vascular surgery at the VA Medical Center there. He went down to Arizona in 1977 to start a vascular surgery program there and was appointed professor of surgery, chief of the section of vascular surgery at that time. In 1980, the same year I showed up as an intern, he came back to Los Angeles, to California, and that was my distinct pleasure, my great chance, and my ability to work with him, as my first rotation as an intern was on the vascular surgery service in July and August of 1980. He led the vascular surgery program there and developed all the things he's done in his career. And he's been awarded the Golden Scalpel Award numerous times for his teaching and began his vascular surgery course there as well. As you know, he's led us in this society as president, and he's also led UCLA for over 25 years with teaching and training fellows, asking those important questions. And he's mentored countless of us sitting in the audience. Please join me in welcoming Dr. Moore for the Homans lecture.
Dr. Freischlag, thank you very much for that generous introduction. And please let it be known that your former mentors and colleagues at UCLA are extremely proud of you and all that you've accomplished during a very young period of time. It's a great honor for me to be asked to give the Homans lecture, particularly in the city of Boston, the home of John Homans. Dr. Homans was long associated with the then called Peter Bent Brigham Hospital, where he was associated with such luminaries as Harvey Cushing and the development of hypophysectomy. But going on to the areas of vascular involvement, it's interesting to note that he was the first to identify the relationship between prolonged airline travel and deep venous thrombosis, often called coach class thrombophlebitis. He also is known for the eponym that is associated with him, the so-called Homans sign. And in this day and age when medical students often are not taught eponyms, I think this is one that they know, even though they may not correctly describe how to elicit it. And finally, he's associated with operations on lymphedema. I've selected as my title for this year's Homans lecture, Carotid Surgery Trials and Tribulations, because arguably of all the operations that we do, carotid endarterectomy was probably been the most studied in the area of the randomized clinical trial. Let's go back a little bit in time and look at this individual, C. Miller Fisher, a neurologist here in Boston, and he's credited with establishing the relationship between disease of the carotid bifurcation and subsequent symptoms, transient ischemic attack and stroke. And it's rather noteworthy that in 1951, he commented that someday it might be possible for vascular surgeons to bypass the occlusive lesion in order to relieve symptoms. So prior to 1954, there have been multiple scattered claims of first-in-man carotid endarterectomy, and I'm not going to get into the debate of who did it first. But I think arguably there's no question that the landmark publication by Escott, Pickering, and Robb really called to the attention that there was a potential surgical solution for the problem of stroke. And on May 19, 1954, at St. Mary's Hospital in London, Mr. Escott was surgically managing a patient who presented with hemispheric transient ischemic attacks. Interestingly, he didn't do a carotid endarterectomy. What he did was to carry out a transposition of the external carotid to the internal carotid artery beyond the lesion and successfully manage this patient. I'm told that among the people standing in the back of the operating theater was Jack Wiley. Jack Wiley was involved early on in development of endarterectomy of the aortoiliac system, and somebody casually turned to him and said, "I suppose you would have liked to have done an endarterectomy on that patient," to which he replied, "Yeah, I would." So here we are. Since that time, there have been multiple single-center series publishing their morbidity and mortality and short-term results. Obviously, those centers with good results published, those that with less good results did not. This went along until this landmark publication in Stroke in 1977 by Don Easton and Dave Sherman, who at that time were in the Department of Neurology at Southern Illinois University in Springfield. And what they thought they would do would be to carry out an audit of all the carotid endarterectomies done in that city. And what they found was rather startling, and that is that the stroke morbidity and mortality for patients undergoing carotid endarterectomy who were asymptomatic was a staggering 18.2%. For symptomatic TIA, the stroke rate was 21%, and the overall stroke morbidity and mortality in the series of patients that they looked at was 21%. Now later on, that similar analysis was carried out by Dick Komchinsky and Tom Brott in Cincinnati, and the numbers went down considerably, but were still unacceptably high, particularly in today's understanding. Along comes Henry Barnett, who at that time was the editor of the journal Stroke, and he joined with his colleagues Fred Plum and John Walton to write an editorial called Carotid Endarterectomy, an Expression of Concern. And in that editorial, he asked the question, are we doing more damage than good when we carry out carotid endarterectomy? And this editorial was a prelude to submitting a grant application to the NIH to study carotid endarterectomy compared with best medical management in symptomatic patients. Keep in mind that Dr. Barnett had just successfully shot down extracranial to intracranial bypass as the result of a prospective randomized trial that was published in the New England Journal. And he was very much convinced he was going to do the same thing with carotid endarterectomy, but he was going to prove it with a clinical trial. Dr. Barnett, when interviewed by 2020, a television program at about this time, was quoted as saying is that carotid endarterectomy is a procedure of no clinical value and should be, quotes, legislated out of existence. And by God, he was going to do it with a trial. Well, that led to the trials in carotid endarterectomy. On the symptomatic side, we had the North American trial headed by him, so-called NASIT. There was a European counterpart, the ECST trial. On the asymptomatic side, there was a VA trial headed by Bob Hobson, the asymptomatic or ACAS trial headed by Jim Toole, and in the UK, the ACST trial. Now, the NASIT design was comparing carotid endarterectomy plus best medical management to best medical management alone. One of the things that they did, which was extremely important, was that they stratified the randomization into two groups by percent stenosis. There was the high-grade group, the 70 to 99%, and the moderate group, 50 to 69%. And the follow-up was projected to be over 5 years. The first thing that happened was that the Data Safety and Monitoring Committee of the NIH called a halt to the phase 1 portion of the trial. And the reason that they called a halt was that during a course of a 24-month follow-up, the stroke morbidity and mortality in the endarterectomy group was 9% versus 26% in the medically managed group. And as a result of that, that portion of the trial was stopped. And here's the Kaplan-Meier curve looking at the event-free survival on the ordinate, showing the very good result with the surgical group and the rather dismal group result with the medical group. Now, the second part of that randomization, the moderate degree of stenosis, did in fact go on to completion, and the results were not quite as robust, but there was still a statistically significant benefit in favor of carotid endarterectomy over medical management alone. On the European side, they had slightly different numbers, but the same trend, and that is that there was a statistically significant benefit in favor of carotid endarterectomy in treating symptomatic patients. Going on to the asymptomatic side, the Veterans Affairs trial demonstrated that the composite endpoint of TIA and stroke and death with carotid endarterectomy had an 8% incidence compared with a 20% event rate with medical management, that difference being highly statistically significant. And here's the Kaplan-Meier curve showing the wide spread between the good results of endarterectomy and those of medical management alone. The ACAS trial initially started out designed very much like the VA trial, but the VA trial came under criticism because TIA was included as a part of the endpoint, so we rather rapidly made this a stroke and death trial as far as the endpoints were concerned. And the ACAS results showed that CEA plus best medical management carried an event rate at the end of 5 years, death and stroke, of about 5%, compared with 11% with best medical therapy alone. That's a 6% absolute risk reduction and a 55% relative risk reduction in favor of carotid endarterectomy. And here's the Kaplan-Meier curve looking at death and stroke alone, with the dotted line being surgery and the solid line being medical management. If you added TIA, in the Kaplan-Meier curves of the ACAS trial and the V8 trial were almost superimposable. The MRC in the UK carried out a similar trial. This was a much larger trial, 1,560 patients allocated to each arm. And here are the multiple analyses carried out in the MRC report, all of which, no matter how they sliced it and diced it, showed the carotid endarterectomy was superior to medical management. So that at the end of 5 years, the stroke and death rate with surgery, 6.4%, with medical management, 11.8%, almost identical with ACAS. So the current status of carotid endarterectomy based upon the results of these randomized trials is that CEA is now the treatment of choice for both symptomatic and asymptomatic carotid stenosis, right? Wrong. Medical management has improved over the 20 years that these trials were conducted, and we now have the positive alternative therapy with carotid angioplasty and stenting. Now, CEA versus CEAS has been also the subject of multiple trials, and I'll just recall the results of a couple of them. The first that I'd like to bring to your attention is the French trial, so-called EVA-3S. That trial was also stopped before it went on to completion by the Data Safety and Monitoring Committee, and it was stopped because the 30-day incidence of death and stroke following carotid endarterectomy for symptomatic patients was 3.9% versus 9.6% for carotid angioplasty and stenting. And here are the 4-year Kaplan-Meier curves for this trial, showing this front-loaded event rate with carotid angioplasty and stenting in favor of carotid endarterectomy. But notice that both of these curves then become parallel and stay parallel, suggesting that if you could get by the high event rate with carotid angioplasty and stenting, the long-term results seem to be fairly comparable with endarterectomy. Next trial was the international ICSS trial. This was a prospective randomized trial comparing carotid endarterectomy with carotid angioplasty and stenting, once again in symptomatic patients. It was done in 50 academic medical centers spread out over Europe, Australia, New Zealand, and Canada. And the primary outcome was a 120-day interim analysis, including death, stroke, or procedural-related myocardial infarction. And here are the Kaplan-Meier curves from that trial to date. The event rate with carotid angioplasty and stenting, 8.5%. Versus 5.2% for carotid endarterectomy. Again, any stroke, 7.7% versus 4.1%. So this now brings us up to the Crest trial. And the Crest trial, bottom line, or top line, I should say, was that the combined endpoint of death, stroke, and procedure-related myocardial infarction, 4.5% in carotid endarterectomy, 5.2% in angioplasty, but that difference was not statistically significant, and it led to the claim by the interventionists that carotid angioplasty and carotid endarterectomy were equal. Well, at this point, I'd like to suggest that there was a design error in the Crest trial, of which I'm afraid I have to take partial blame because I participated in its design. And it's important to point out that if you simply add endpoints, death, stroke, and MI, what in fact you're saying is that a Q-wave MI is the same thing as death, which is really preposterous when you think about it. Now, all primary endpoints, death, stroke, and MI, are important, but should have been weighted according to severity. Now, how might we have done that? Well, the first thing that we did in Crest was to ask the patients who had a complication compared to those who did not, What was the worst thing that could happen? Obviously, couldn't ask those who died. That was clearly the worst thing that could happen. But of those that managed to live, the worst thing that could happen was a major stroke. The next worst thing that could happen was a minor stroke. And a year after the event, myocardial infarction fell right on the median. So at least from the patient's perspective, that was a non-event at that time. So let me suggest for your consideration that a grading scale that we might have used, and this is arbitrary and it's something that I sat down and did one evening, and what I did was to assign 10 bad points to death, 8 bad points to major stroke, 7 bad points to minor stroke, and 5 bad points to myocardial infarction, and applied that to the actual data from the Crest trial. Now, in Crest, 9 patients undergoing angioplasty died. That would have given them 90 bad points. 4 patients undergoing endarterectomy died. That would have given them 40. Major strokes, 11 major strokes in CAS, 88 points, 8 major strokes in endarterectomy, 64 points. Minor stroke, 41 minor strokes in CAS, 287 points. Half that number, 21 in endarterectomy, 147. And where CAS does better than endarterectomy is in the area of myocardial infarction, only 14 in CAS, twice that many in endarterectomy, 28. But if you add up all the points, 535 bad points for CAS, 391 for endarterectomy, and that difference was in fact statistically significant in favor of endarterectomy. So if we now go to the bottom line in Crest, looking at the traditional endpoints of death and stroke, 2.3% in endarterectomy, 4.4% with angioplasty. That difference was highly statistically significant in favor of endarterectomy. So from my perspective, in symptomatic patients, carotid endarterectomy is still preferable to either angioplasty or medical management. But what about the asymptomatic patient? It is now alleged that modern medical management has lowered the annual stroke risk in asymptomatic patients from what had previously been the case of 2% per year down to 1% per year. And at that event rate, this would, if correct, would no longer make endarterectomy useful and perhaps harmful when compared with best medical management alone. So in order to test this hypothesis, we now have Crest 2. Crest 2 is now funded. We're now recruiting centers. We're getting ready to begin. And this will be a prospective randomized trial comparing in parallel fashion endarterectomy plus BMT versus best medical therapy alone, and carotid angioplasty plus BMT versus best medical therapy alone. So the trials and tribulations will continue. Stay tuned. Thank you for the privilege of the opportunity to deliver this year's Homans lecture.